Now moving on to Emma Pacey. Emma, what concerns do you have regarding children's oral health at present?
Yes, I think probably sort of kicking off most recently, we had the publication of the National Oral Health Survey of 5-year-olds, which found oral health improvement to have plateaued. And so, we currently have a situation where on average, almost 1 in 4 of our 5-year-olds experience decay, and those that have it, on average, 3.4 teeth are affected. And the trajectory from 3-year-olds is steep, with decay experience doubling. It's largely preventable, of course, as we know. And so the question really is whether we value the oral health of children in our society, and if we do, what we're going to do to tackle it. Evidently, we all know the pain, distress, disturbed eating, sleeping, working, the way in which decay experience impacts, but it also follows a pattern that tracks overweight, obesity. And so in other words, those with decay experience are also more likely to be overweight, obese. And so arguably, tackling it is even more important. And these risk factors are, we know they're not easy to address. If they were, we'd have a handle on them, and we wouldn't have seen a plateauing in health improvement or oral health improvement. We need to acknowledge, I think, and this has been alluded to already by Sir Paul, that the current system is no longer fit for purpose, and understand better our complex health behaviour and come together to tackle them in a coordinated approach. Specifically in relation to COVID and concerns, I can possibly speak collectively and say that there is additional concern. Everyone's daily routines have been disrupted, income affected, and priorities shifted, which impact, of course, the way we're able to care for ourselves, and specifically the food we eat and our daily hygiene practice. And this, of course, has been compounded by the withdrawal of primary care. In secondary care, of course, we have seen less people attending, even where the provision has remained open. And by extension, again, I think it's fair to say there are concerns being expressed about what impact this will have on the rate of GAs being provided for dental decay. And Sir Paul's already mentioned, so I won't, reiterate the fact there. But most importantly, I think poor oral health, like general health, is an issue of inequality. And arguably that is the greatest risk factor for both infectious disease, i.e. COVID, as well as non-communicable diseases such as dental decay. And it is increasingly becoming a conversation that we're having nationally and internationally. And the pandemic has seen this surge, and I think it provides an opportunity that we can monopolise on in terms of that conversation.
Yeah. No, I totally agree with you there, Emma. And what are you currently working on to overcome these?
Okay, so I split my week between Health Education England and King's College Hospital. At Health Education England, you may well be aware, we work to ensure the healthcare workforce is reflective of the health needs of our population, and that it's agile in its response to this. And I'm sure you can appreciate that COVID has probably presented our steepest, indeed the NHS's steepest learning curve to date. So we've obviously seen, in terms of what I've been up to recently, mass remobilisation of the workforce to support the COVID response, for, example, into transferable roles within NHS Trust, to Nightingale Hospital's NHS 111, track and trace. But we are now returning from crisis management to sort of the new normal, so to speak. And this is centred on training. And in our region, I'm based in London, Kent, Surrey, Sussex. We are year on year increasing our public health offer and mobilising the substantial sort of dental workforce that we have in a sustainable way across the life course. And this, of course, includes children, in terms of interventions at that age group. In terms of my work at King's, we're commissioned to promote oral health across 9 local authorities, and we're currently mapping out how this will look in the COVID context. In terms of young children's oral health, and again, this reflects some of what Sir Paul has said, some of the population level interventions have had to be paused due to the risk of disease transmission, and this is just temporarily, such as supervised toothbrushing. So, at the moment, we're looking to reorientate our offer and focus on lower risk interventions such as distributing oral health packs and working in coordination with other initiatives such as food banks and voucher and supplementary schemes. And since the announcement of free school meals over the summer holidays, we've been exploring opportunity there too, to piggyback on that. A large part of our current focus, as I'm sure you can appreciate, is how to deliver health promotion virtually in an impactful way, which does mark a gear change from how we have historically really engaged communities, particularly those that are on the fringes, so to speak, face to face. But at the same time, this change does provide opportunity.
Absolutely, and I think that's what we're going with, isn't it? And exciting opportunities of how we can move forward. So what challenges do you see arising? You've gone over a few aspects of it, but associated to the number of actual appointments missed resulting from lockdown and COVID-19?
Yeah, I mean, obviously, I think sort of priority really is the long-term health consequences and the reduced, due to the reduced access to care, or rather focusing on that aspect of your question. I think a concern there again is that the reduced access does disproportionately affect deprived communities. And additionally, safeguarding opportunities are reduced. But now, of course, primary care is opening up. And between primary and secondary care, we're really tackling, the extensive waiting lists and prioritising in the process, which I think is a new decision sort of making process that we're entering into, really. COVID, I think, as we've already alluded to, but it has pushed us to our limits, but it's also showcased the value and transferability in our skill sets. And I think also brought into stark relief what constitutes necessary care and the need to widen access to the public. And in that, I'm thinking about skill mix, again, to reflect on something that Paul's just said. So I think what's interesting is what it has taught us and what we can learn to take forward. So for example, what is a risk assessed recall, and how best can we utilise the whole team to widen access? The current system, as we know, does present barriers to this.
Sure.
How we can engage our patients in behaviour change, as I said, whether or not we can deliver, how we can deliver oral health education virtually, and what current evidence-based procedures can we provide in a low-risk environment, because the fast hand piece has been put down. And I have further comment to make on that, but I won't in the interest of time, and that this is possibly treading on far more eminent individual who's coming up, and I've no doubt we'll be covering that. So yeah, but I mean, the good news is in districts we can provide, I think it's fair to say, the majority of evidence-based care in a no AGP environment.